Welcome to this compact echo series. In this lecture series, I will show you all the possible views you can acquire to scan the heart. The heart is truly a fascinating organ, and as you can see, there are plenty of views, plenty of modalities you can use to get information out of your loops. But how do you do that? How to even start your journey in echocardiography? Well, first of all, we need to understand all the different cut planes we have and where to actually start. The cut planes are shown quite nicely here in this graphic. In this graphic, you can see that there is a parasternal window, an apical window, a subcostal window. Those are the windows you will mostly need in your echocardiographic exam. For specific questions, for example, in case of severe aortic regurgitation, you might use the suprasternal window, and to even further grade or even better grade aortic stenosis, you might need the right parasternal window. Let's start with the first view you always want to start with in a standardized approach in echocardiography. It's the parasternal long axis view. Why parasternal? Of course, it is in the name. You place the transducer right besides the sternum. The sternum is a bone located over here, and you want to be on the left side of the sternum. In case of scanning the heart, you should start really at the clavicle. So touch your patients, try to feel the clavicle and put the transducer, place the transducer directly below the clavicle. If you do that and then just move downwards with the transducer, you simply cannot miss the heart. The mark of the transducer always is located to the right shoulder of the patient. The patient has to be in the left lateral position, then imaging will be easier. So the key points are that parasternal long axis view, mostly in most of the patients, you will get quite a nice image. Sometimes it simply doesn't work that well, for example, in patients with COPD or morbidly obese patients. The patients, as I said, they have to be in a strictly lateral position. If they are not, it's harder to scan, so place them really left laterally and scan as close to the sternum as possible. As I said, the marker always points to the right shoulder. Don't point it cranially, don't point it to the lateral side, really to the right shoulder. And mostly the view you want to acquire is located in between the second to probably the third intercostal space, but don't be discouraged if it's sometimes in the fifth or even sixth intercostal space. That simply can happen and is very, very different in the patients we see. And once more, start really at the clavicle. If you do that, the parasternal view is relatively easy to acquire. Here you see this nice cut plane of the heart, and over here the right ventricle is located, so this is close to the transducer. This is the mark of the transducer. In echocardiography, the marker is always in the right side of the image, and he is close to the transducer. And this is your field of view you can acquire. And starting from the top, the first anatomical structure you will see is the right ventricle. Always pay attention to the right ventricle, because you can get a lot of information only in this view already about the RV. Then there's the interventricular septum, there is the left ventricle. The mitral valve is a very important valvular structure you already can visualize in the parasternal long axis view. This actually is anteroseptal, and this is the posterolateral wall. So it's not strictly posterior, but the posterolateral wall. In this view, you already get a lot of information about the aortic valve located over here. There's always the right coronary cusp located towards the right ventricle. And if you differentiate the right coronary cusp from the other cusps, you might already get an idea where regurgitation or a leaflet restriction or probably a prolapse is located. Here's another important structure you will scan in a later stage in this view as well. It's the ascending aorta, and basically that concludes the most important anatomy of the parasternal long axis view. One tiny structure we have to mention in case of the parasternal long axis view is the coronary sinus. It will be located over here. You will see it in the next slide. The first view you want to acquire, so the first view of our entire echocardiographic exam, is an overview of the parasternal long axis view. So use a lot of depth, approximately let's say 18, 15, 18, maybe 20 centimeters even, to visualize the descending part of the aorta and to differentiate in between. There might be a pericardial effusion. The fluid will be located in between the descending aorta and the heart, so in the pericardial sac. If it is outside the aorta, it already hints towards a pleural effusion. So you already can scan the heart and the lungs in the first view you're acquiring in your entire echocardiographic exam. Moving on to normal anatomy, as I told you, and you can see it in this loop quite nicely, start always at the clavicle. Move down the clavicle until you reach this view. As soon as you reach the heart, you do stop and take a bit of time to evaluate the normal anatomy again. What we can see here is close to the transducer, the right ventricle. This is the left ventricle. The ascending aorta you can see already parts of. This is the aortic valve, the right coronary cusp, and this is the non-coronary cusp or left coronary cusp. Here's the left atrium, the anterior mitral valve leaflet, the posterior mitral valve leaflet, and the posterior lateral wall. This is already the anatomy you can see. The coronary sinus is located over here, but it's really small, so sometimes it's not even possible to visualize. Pay attention if you have right heart failure or elevated pressures in the right heart, you might already see the coronary sinus in this view to a larger extent. Adding color Doppler in this image is already very important. You can first place the color Doppler on the mitral valve, so you shouldn't do it on both valves at the same time. So record one loop with the color Doppler across the mitral valve. You see here a little bit of a mitral regurgitation. This is not uncommon to see, so you don't need to be worried about that. But keep it in mind that in the parasternal long axis view there was a tiny or mild mitral regurgitation, just to take another look in another view. Second, place it across the aortic valve. Here you see the aortic valve. Also across the aortic valve there is an insignificant jet. So you see here a tiny jet as well. Still keep it in mind to scan it in more planes. So the parasternal long axis view is also really an entire overview of all the structures you can see in the heart. So some small or minor pathologies we already found. As I mentioned, you basically should place the color Doppler across one valve at a time and record 2 loops. I do understand that in daily clinical practice sometimes that's very hard to do because you at least feel stressed. Even if you are maybe not stressed, there is always a lack of time to scan more patients because patients are in need of the exam. So what you also can do alternatively, but still I wouldn't recommend it, even though I have to admit I do it in my daily clinical practice, as you can see here as well. Place the Doppler, the color Doppler across both valves, and here you can see the mitral valve and the aortic valve. Still, you should try to avoid it and scan each valve individually. This is another healthy example, and in this example you see that here is, for example, the descending aorta. There is also probably some mitral regurgitation present over here. Over the aorta I do not see regurgitation at all. There's also blood flow in the right ventricle. One more important tip I want to give you is that the color Doppler shouldn't be too broad. So the area of interest or the region of interest should be really small. The length doesn't matter, but if you make the color Doppler very, very broad, you lose frame rate. So make it as narrow as possible, but that you still see all the important pathologies you want to visualize. So in case of a mitral regurgitation, make it as broad as needed to visualize all the regurgitation, but don't make it too broad because you will simply lose quality. Moving on to another structure I wanted to show you towards the ascending aorta. So how do you scan the ascending aorta? Well, it's basically very easy. So sometimes you just scan it in a normal parasternal long axis view. If not, simply move one intercostal space up. And if you do that, you will be able to visualize the ascending aorta over here. Measure it, and if it's above approximately 38 millimeters, it's pathological. The ascending aorta also should be documented in each and every echocardiographic exam. There are some more standard views you have to acquire in case of the parasternal long axis view, and one view is focused on the aortic valve. It's quite natural that if the aortic valve does have a pathology, you want to visualize as much of the structure as possible. So you should zoom in to specifically see the aortic valve. And this is the aortic valve. Here you see the ascending aorta. This is the LVOT, so the left ventricular outflow tract. There's again the right coronary cusp and the non-coronary or left coronary cusp. So focus a view on the aortic valve. You can see that the aortic valve is calcified, the cusps are calcified, but the opening of the aortic valve still works fine. The second view you have to acquire after the focus of the aortic valve is the mitral valve you want to focus on. So you want to focus on the anterior part of the mitral valve leaflet and the posterior part of the mitral valve leaflet over here. In this loop, you have to focus on the mitral valve. So zoom into the mitral valve, try to visualize the opening and closure of the anterior mitral valve leaflet and the posterior mitral valve leaflet. If it's opening quite nicely, that also points you towards a normal left ventricular function, as we have seen in all the examples before. If it doesn't do that, or if there's a restriction or a doming of the mitral valve, you might see stenosis already, even in the B-mode image, or get hints towards mitral regurgitation. This concludes the first part of the normal anatomy of the parasternal long axis view. We will move now on towards the pathological findings and a very important topic, the atypical views. In the past few videos, we talked about the normal anatomical findings in a parasternal long axis view in echocardiography. It's time to move on to pathological findings. To review what we have learned, we did talk about parasternal windows, the parasternal long axis view, the marker pointing to the right shoulder of the patient, and you're located on the left side of the sternum, so parasternal long axis view. How does the anatomy look like? You do see the right ventricle displayed over here, the left ventricle seen here. These are the chordae tendineae, the papillary muscles, the anterior, the posterior mitral valve leaflet. This overall is the mitral valve, the left atrium, the LVOT, the aortic valve, the right coronary cusp of the aortic valve, the left or non-coronary cusp of the aortic valve, and the ascending aorta. So we do have a lot of normal anatomy to understand and to consider when we talk about the parasternal long axis view. But let's move on to pathological findings. In case of a pathology, we see here a loop again. We do see here is the pericardium, this bright hyperechoic layer. There's the interventricular septum, the posterolateral wall, the mitral valve, the aortic valve, the LVOT. And this loop already looks entirely different compared to what we have seen before. But how is it different? Let's review what we do actually find. What we can say for sure is that the myocardium seems thickened. We want to measure the myocardium. Over here we do see also there's a little bit of a septal bulge over here, but there is no outflow obstruction, no SAM. But the myocardium is definitely thickened. The posterolateral wall seems also thickened, but compared to the septum, it's a little bit thinner. So we have a septal predominance of myocardial thickening. You can already do this in this B-mode image. You can also alternatively use M-mode. I have to admit that in these cases, I never use M-mode, sometimes only for teaching purposes to visualize the structures a little bit better, but overall measure it in a 2D image. We can discuss about left and right ventricular function already. Here you see this is the wall of the right ventricle, and compared to the image we have seen before, it seems a bit different. It seems a bit, so to speak, weaker. We cannot be sure yet, but you already got a glimpse of the right ventricle, and you have to keep it in mind when you assess right ventricular function. The function of the left ventricle also seems to be not entirely normal. I wouldn't grade in regards of ejection fraction here. This is not the view to measure with the Simpson method, but we have to keep it in mind that left ventricular function also seems reduced to a certain degree. Wall motion abnormalities I also want to discuss, but still I wouldn't be entirely sure if there might be some specific wall motion abnormalities. We need more views, but we have to keep it already in mind. Let's move on to another pathological example, and every one of you will already know that this cannot be normal. In this case, we have the interventricular septum over here. It's basically akinetic. It's very, very thin. It looks like a scar. We do have the posterior lateral wall. It's a bit thicker. Left ventricular function seems to be impaired, and also focus on the valves. Here, this is the aortic valve. The ascending aorta is normal in size. This is the mitral valve. So in this view, you have plenty of information how this patient might be doing. If we add color Doppler, we get even more information. In color Doppler, we do see a regurgitation over here and a regurgitation over here. So there is mitral regurgitation present and aortic regurgitation. Look at all our findings. We definitely can say that left ventricular function is severely impaired. This definitely cannot be normal or mildly impaired left ventricular function. As little as the heart is already doing in the parasternal long axis, we know what will follow in the other views we can acquire. Right ventricular function I also want to discuss because it also seems different compared to the normal anatomy we saw. If it is truly impaired or not, we can assess later, but it already gives us again a glimpse of the right ventricle. Note as well the premature closure of the valves. So if the heart is pumping less blood or the stroke volume is decreased, the ejection fraction is decreased, there is less blood flow going out, and because the heart is not pumping normally, the valves are closing before they actually should. So this is a premature closure of not only the aortic valve, but also the mitral valve. You see how weak it is opening and how soon it is closing again. In a young, healthy individual, it's opening and closing really, really strongly. So there's a whole lot of difference in between those two images. We do have a certain degree of aortic and mitral regurgitation. We have to keep that in mind because all regurgitations we will see will burden the left ventricle with even more volume. So a volume burden due to regurgitation is another marker how the patient might be doing. Another thing we can already visualize in this view, and this is so fascinating about B-mode imaging. In this view, if you really take a close look over here, if you take a look how the mitral valve is closing, there already is a coaptation defect of the valve. So the valve cannot close entirely. And you can already visualize it in a parasternal long axis view. So pay close attention to each and every single detail of the valves, of the left, of the right ventricle, of the aorta to really get an overview of the heart. Wall motion abnormalities we already discussed. Also keep that in mind for later views. If we move on to the next patient, we will again see a case of aortic regurgitation, but I want to focus your attention on this structure here. That's the bulbous of the aorta. So this is the aortic valve, this is the ascending aorta, and this structure over here is definitely enlarged. There's another structure we can see over here. It seems echogenic. It's also visualized over here. This is a patient who had a rupture of the aorta, and this is a prosthesis of the ascending aorta. So also keep that in mind if you see that. The aortic regurgitation doesn't seem to be just minimal or trivial. That we also have to remember for the next views. If we follow on, we can see this dilatation of the bulbous. We do see AR. We also see a certain degree of MR, the ascending aorta replacement. And also, if we do take a look on the myocardium, we see that the myocardium is thickened. There is no outflow obstruction happening yet, but the thickened myocardium we can visualize. One last case I want to show you in the parasternal long axis view. Take a close look at this heart. Do you see any kind of probably pathological finding? Let me walk you through it. Let's start with the right ventricle. The right ventricle seems to be normal in size. You can measure it here as well. Here you see the wall of the right ventricle. It's contracting basically normally. Let's move down to the aortic valve. The aortic valve seems to be fine. There is no calcification, no leaflet restriction. It seems to be a normal opening and closure of the valve. The ascending aorta seems to be normal. The left atrium, I would also say it's probably normal, maybe a little bit enlarged, but I wouldn't grade it here. The mitral valve also looks normal, but now it's becoming a bit trickier. Focus on the interventricular septum and the posterolateral wall. And what you can see is that the basis here is contracting quite nicely and normal. And over here you do see that there is definitely not normal contraction. So if we move on and see what we can describe in this loop, it's that the left ventricle probably is dilated to a certain degree. So you see that there is definitely a wall motion abnormality, and that we have to keep in mind for further evaluation. So this is a patient who probably has coronary artery disease, or a patient during an infarct or after an infarction of the heart. Why can it be too old, or why is it not a scar? The myocardium, at least in these views, doesn't seem to be thin and hyperechoic. So I would guess that this is not a scar yet, but we definitely have to evaluate further. This already concludes the pathological findings of the parasternal long axis. There are way more pathological findings, there are way more pathologies you already can see in this view. We'll talk about atypical views of the parasternal long axis. Well, what are atypical views? We discussed already the normal views of the parasternal long axis. You are located on the left side of the sternum, the marker pointing to the right shoulder of the patient. And what we have to discuss, or what we have to acknowledge now, is that there are atypical views. How do you acquire them? Well, there are two views specifically we want to visualize. The first atypical view is the parasternal long axis view of the right ventricular inflow. Why is that important? How can you acquire this view? It's actually pretty easy. You are located in your parasternal long axis view, marker pointing to the right shoulder, and you just tilt. You tilt the transducer downwards. So for me, the transducer tilting downwards is where the beam of the ultrasound is going. So it's going caudally. So not upwards, but downwards. So tilt the transducer in this direction. If you do that, you will get a nice view of the right ventricle. You can see the right ventricle over here. This is the right ventricle, the cavity of the right ventricle. You can see it in this B-mode image over here. Don't get confused. This is the left ventricle. This is the right ventricle. And now we are focusing on the right ventricle and the structures in the right heart. This is the tricuspid valve. This is the right atrium. Here you also see the right atrium, and what's really nicely visualized here is that you can differentiate in between the anterior and the posterior tricuspid valve leaflet. This is, at least from a transthoracic approach, only possible in this view. You cannot see the anterior and the posterior leaflet of the tricuspid valve differentiated in any other view. It's very important. For example, in case of drug abusers, they can have endocarditis of the tricuspid valve. You can visualize it in this view quite nicely. This is the anterior leaflet. This is the posterior leaflet. Most structures we can see is here this inflow, therefore it's called RV inflow, so from the right atrium to the right ventricle. And the right ventricular inflow is the coronary sinus and the IVC, so the inferior vena cava. Sometimes the view doesn't look that nice. It also can look like this. You see here the tricuspid valve, the anterior, the posterior leaflet. This is the right atrium. Still we see the right ventricle to a certain degree. We can also differentiate the free wall of the right ventricle a little bit over here, but definitely the image quality is reduced. Still the information we get can be crucial. Adding color Doppler, we are back here in the B-mode image. Let's visualize again the anterior, the posterior tricuspid valve leaflet, the coronary sinus, the IVC, the right atrium over here, and this is the right ventricular wall. And you can see here with color Doppler the inflow into the right atrium quite nicely over here, and then also the inflow into the right ventricle. And this is very nice to visualize because over here you would see tricuspid regurgitation. But why do you need this view? You can do that from an apical view, for example. I will show you why, because already in this view you can see the difference in between here normal right ventricular function and here where we said before this might be reduced right ventricular function. It's distinctly different. Also, if you take a look at the tricuspid valve over here, the nice opening and closure of this young and healthy individual versus this valve over here. Here you can see the valve is opening, but it's by far not that strong. There is also a dilatation of the right ventricle if you compare the right loop or the loop on the right side versus the loop on the left side. The dilatation of the right ventricle over here, and there's dilatation of the right atrium as well. So what do we expect from the right-sided patient? We do expect that there is a certain degree of reduction in right ventricular function. We do also think that there might be tricuspid regurgitation, and definitely the inflow is impaired compared to the left side. We can visualize it now with color Doppler, and we see this reduction in right ventricular function and also the tricuspid regurgitation. What's quite good to see over here is the vena contracta, and also PISA measurement could be possible in this view. I always perform this view, so the inflow view of the right ventricle in the parasternal approach, because it gives a lot of information about the right ventricle, about the inflow of the right ventricle, about right ventricular function, about tricuspid regurgitation, and especially in some cases, if you cannot visualize tricuspid regurgitation in an apical window, you can always go back to the parasternal window and try it in this view. Why is it so nice? Sometimes the CV Doppler just has the perfect angle to measure systolic pulmonary arterial pressure in this view. To continue with another example, I want to show you another reduction in right ventricular function, but probably it's a different origin. In this case, you see that there must be thickened myocardium. Here's a little bit of a different angulation of the same patient. So the left loop and the right loop, they are same patient, so this is the same person, but it's a little bit of a different angulation. And here you see probably the interventricular septum, and here you see another parts to the posterolateral wall of the left ventricle. Here you can see the right ventricular inflow nicer, but you also can visualize that there is a degree of right ventricular thickened myocardium as well. So it's not only the left ventricle which has thickened myocardium, but also the right ventricle. In this view, you can see that the opening and the closing of the tricuspid valve is entirely different compared to a healthy individual, and you see that the inflow of the coronary sinus is more prominent. Also, the inflow of the IVC over here is more prominent compared to the healthy individual. This probably is the descending aorta, so this is the inflow, this is the coronary sinus. And both loops show that the tricuspid valve, the anterior and the posterior leaflet of the tricuspid valve, can be nicely differentiated. If we then continue and add color and continuous wave Doppler, in color Doppler we can see nicely, here we can see a little bit of the inflow into the right atrium and the inflow into the right ventricle from the right atrium, but we also see the tricuspid regurgitation. Here you can see tricuspid regurgitation. You can also grade it over here. Here it's probably moderate. And if you place a continuous wave Doppler, you can see that the signal is around 3 meters per second. So they are elevated systolic pulmonary arterial pressures, and it can be measured here quite good because the TR is just perfectly in the angle of the continuous wave Doppler seen over here. The second atypical view of the long axis, I have to admit, I do not perform it on a regular basis, only if I cannot perform it in a parasternal short axis. What is it called? It's the parasternal long axis right ventricular outflow view. What is the outflow? Of course, it's the right ventricular outflow tract, the pulmonic valve and the pulmonic trunk. And you can see it over here. This is the valve. This is the right ventricular outflow tract. You also can see the motion of, or the right ventricular function of the right ventricular outflow tract, which also contributes to overall or global right ventricular function. And here you can see the pulmonic trunk. And this is a nice view where you can also measure, for example, the pulmonary acceleration time. So if you cannot do that in a parasternal short axis view, I always try to achieve a view in the parasternal long axis to see the outflow as well. And here you see the acceleration time of the pulmonic valve, which is normal in this individual. Here you can also appreciate the color Doppler signal. The color Doppler signal also looks normal. There is no turbulent flow actually to be seen. Here you can see the pulmonic trunk and even parts of the right pulmonary artery and the left pulmonary artery. How is this view acquired? Instead of tilting down so that the beam goes caudally, you tilt up from a parasternal long axis view. You tilt cranially, so the beam goes cranially, and then you will see the outflow tract of the right ventricle. Place the pulse wave Doppler, try to acquire this view. It doesn't work in all your patients, but in some you will get really nice images there as well. To summarize it, let's look at the pathological example. There's also the patient we have seen before with probably reduced right ventricular function. We do see here the pulmonic valve, also the opening and the closure even of the pulmonic valve is different. We do see pulmonic regurgitation. It's definitely not severe. We can see the pulmonic trunk and the right pulmonary artery as well a little bit, and it seems to be dilated compared to the other images we have seen. Now with these specific views, the atypical views, which at least you should try to learn and then use it in the situations you need it, we will conclude the sessions of the parasternal long axis view. I hope you enjoyed it. I hope I didn't miss some views, but with what we have learned and visualized on the specific EchoPack software and with these cases, I think you got quite a broad overview over the topic of the normal and pathological findings of a parasternal long axis view. Please post your comments below. Let me know what you think. So if you have any suggestions, if you know any other views, maybe I did miss a view, let me know in your comments. If you did enjoy the video, please don't forget to share, like, subscribe to see more interesting cases, not only of the parasternal long axis view, but of all of the views of the heart together. And I will continue with this compact echo series with the parasternal short axis view. I hope to see you there, and thanks for watching.